Okay, we will make a start if we can. Welcome everybody to this session on improving health through improving healthcare financing in the Asia Pacific. My name is Professor Anthony Scott. I am Director of the Centre for Health Economics in Monash Business School at Monash University. But first of all, on behalf of the event organisers and all of our speakers today, I'd like to acknowledge the traditional owners of Nam, the peoples of the Kulin Nations, on whose country we gather for this event. We pay our respects to the elders past and present, and to elders of all First Nations communities that are joining us here today. We undertake to walk together with respect with Aboriginal and Torres Strait Islander peoples, communities and organisations in a shared journey to better health. We recognise the ancient and diverse cultures of Australia's Indigenous peoples and strive to consider them in our quest for health equity for all. We'd also like to extend our acknowledgement to all First Nations peoples and recognise their unique, crucial and enduring contributions to societies all over the world. This session is about healthcare financing, and we can't improve health without resources, and using those resources to improve equity and using those resources to their best effect. So this is an important session that we feel underpins the ability to meet our health and equity objectives. I'm the chair for this session. The moderator, which I'll hand over to you now, is Luis Viñals-Torres. He is the Director of the Division of Health Systems and Services, the World Health Organization, Western Pacific Regional Office. Luis, over to you.
Thank you very much, Tony. Good morning, everyone. I don't know how many of you are health financing experts or are you interested on health economics, but I hope that by the end of these 90 minutes, we will get some of you to the course on health financing. We have prepared a very interesting journey for this session. We are going to talk about aid effectiveness. We are going to talk about the overall situation in the Asia Pacific on health financing, but we are also going to countries. We're going to go into Fiji, we're going to go into PNG, and we're going to go to Indonesia, and even we're going to talk about economic evaluation. As you can see, it's quite a packed session, which could be like a mini master on health financing for you. Let me start. We will have, it's very busy and rich session with fantastic speakers, but let me I want to make two comments before we start. The one is we are going to try to cover a very diverse region. And I just want to quote two numbers here. Australia spends more than $6,000 per capita on health. One neighboring country spends only $60. So you can imagine the difference on the possibilities that you have. But one of the important things on health financing is not about the volumes, the quantity of resources available, but on the way how they are spent. And that's my second point. On the progress towards universal health coverage, health financing has a critical role. It is one of the most powerful policy levers that countries can use to pursue, to progress towards universal health coverage. Let me put you an example because I guess that most of you are Australians, so I'm going to use an example from Australia. The way how you pay medical doctors or patients is fee-for-service. Fee-for-service, for those that have not done yet the master's degree on health financing, it incentivizes the use of services because the providers have an incentive to provide more and more and to give more and more because they are rewarded to do that. So the choices that you are having in your system, it will determine what you get in quantity and quality. And this is just a very small example of how health financing decisions matters for your system. Having said that, let me start with the content. So our first speaker for this journey is my friend, actually before anything, my friend Dr. Ajay Tandon. Ajay is a lead economist with the World Bank, global practice on health, nutrition, and population. And he's probably one of the persons in this planet that knows the most about health financing in Asia and Pacific. So it's a great privilege to have him in our panel. Over to you, Ajay.
Thanks, Luis and Tony, and especially to Luis for that exaggerated introduction. I just have a couple of slides landscaping the Asia-Pacific region, in particular landscaping it with regard to health financing and also to universal health coverage. And I just wanted to start by just saying that what do we mean when we say Asia-Pacific? And we've heard this point over and over again about how diverse the region is, how dynamic it is, and also how consequential it is. When I say Asia-Pacific in our parlance in the World Bank's group, it's including South Asia as well as East Asia and Pacific. For WHO, this would be WIPRO as well as CRO regions, for those who are familiar. So yes, the region is very diverse in many ways in terms of size of the economies, the size of the population, but it's not very diverse in terms of national income. So it's really largely a middle-income region. If you exclude Australia, New Zealand, Japan, Korea, and Singapore, most people in this region live in countries that are middle-income countries. And in fact, most of them live in countries that are lower middle-income countries. So just wanted to keep that in the back of your heads. And by lower middle, I'm meaning the World Bank's classification that if your national income is $1,000 and below, you're considered low income. If it's roughly between $1,000 and $4,000, you're considered lower middle income. And if you're from $4,000 to $13,000, you're upper middle income, and above that, you're considered to be high income. So most countries in the region are middle income, lower middle income. However, even with these similarities of income, there's a huge diversity in terms of how health is financed across the region. So this is just giving you a very big helicopter view. I've tried to condense as much as possible into three graphics. I hope this is clear to you. I've sort of separated it out into South Asia, the South Asia region, developing East Asia, which for us is Southeast Asia as well as China, Mongolia, and the Pacific. Now, these are not population weighted. These are country weighted averages. If I do population weighting, it'll all be China or India that'll show up. So these are just average. And you can see there are big differences in terms of how health is financed. This is showing you total health spending per capita over time from 2000 to 2021 using the latest data from WHO's Global Health Expenditure Database. It's showing you, for instance, in South Asia, in real sort of per capita terms, total health spending doubled from roughly $100 per capita in 2000 to about $200 per capita in 2021. And also I'm showing you how that health spending is financed. So sort of the khaki color is spending financed with general taxation. The purple is social health insurance contributions. So this is how much money is raised by the mandatory social health insurance wage-based taxes. The black is external financing that flows through the government budget. The yellow is external financing that goes outside of the government budget. Red is out-of-pocket spending. The light blue is voluntary health insurance, and the gray is other sources of financing. So big differences across the region. There's no social health insurance in South Asia. There is some social health insurance in developing East Asia, and a little bit also in the Pacific. South Asia, still out-of-pocket spending is large. In fact, it's the largest source of financing for health in that region. Although over time, earlier on, it used to be 52%. In 2000, it was 52% of total health spending. Now it's down to 48%. It's still the largest source, whereas in developing East Asia, the sort of out-of-pocket spending has declined. So now the largest source of financing in developing East Asia is public financing, public meaning general taxation as well as social health insurance, and out-of-pocket spending is roughly 1/3. The Pacific has traditionally not had high out-of-pocket spending, so where the Pacific stands out is the sort of the big role for external financing that still remains, and the Pacific spends a lot more. So people are familiar with the epidemiological transition, with the nutrition transition, with the demographic transition. So we health economists wanted our own transition, and what you're seeing here is developing East Asia making progress towards its health financing transition, so that it's moving away from dependence on out-of-pocket and external financing towards more and more public financing, which is really the definition of a health financing transition, with South Asia not making that as much progress on that front. Pacific sort of already had achieved its health financing transition in terms, but although that doesn't necessarily mean, to echo Luis's point, that they're doing relatively well in terms of how they use the money in terms of getting outputs. Anyway, that's just a helicopter view, regional averages. I'm just going to give you a little bit more of country specificity. This is just now splitting up those numbers you were seeing earlier by country. And one of the sort of stylized facts globally is, for instance, there's a negative correlation between public spending on health as a share of GDP, which is on the x-axis, versus out-of-pocket spending as a share of total health spending. As you can see, many countries still depend a lot on out-of-pocket spending. Out-of-pocket spending is a risk factor for impoverishment due to health shocks. It's an inefficient, inequitable way of financing health systems. Out-of-pocket spending is a tax on the sick. And you can see that many countries that have high out-of-pocket spending as a share of total health spending also have low public financing for health. And the challenge that many countries in our region face is, how do you sort of increase public financing for health in ways that will crowd out-of-pocket spending and also make progress towards service coverage? And this is not just one point on a graphic. So low public financing for health shows up as lack of medicines and facilities, lack of human resources, lack of diagnostic facilities, long waiting times, and so on and so forth. So there are consequences to not spending enough, and in particular, one consequence being low quality of care, which causes problems in a variety of ways. Just wanted to add a footnote slide here as to why public financing for health has tended to be low in many countries in the region. There's a mathematical relationship. It's the equation on the top that public spending on health is a share of is really a function of the size of the economy, the size of the government in the economy, and then health share of government spending, and that's determined by government revenue generation and so on and so forth. And if you take a look at the graphic that's showing you per capita income on the x-axis and public spending on health per capita on the y-axis, South Asia and East Asia, developing East Asia, tend to spend much lower than expected for their income levels in terms of public financing. And one of the reasons that happens is, on the right-hand side, is that overall government revenue generation is quite low. It's actually the lowest in developing East Asia across all regions. And in addition, South Asia also suffers the problem that health's share of the government budget tends to be very low in South Asia. So you have 4% or 5% being allocated to health. The global average is about 11%. So a combination of those two factors has led to this sort of problem of low public financing for health, the consequences of which are high out-of-pocket spending. Just very briefly, to switch gears, I'm going to also give you a very brief landscaping of where the region is in terms of making progress towards universal health coverage. Just to make a point that this is sort of the WHO slide that takes the 3 building blocks. And Luis, yes, there are 3 building blocks. WHO sometimes has 3, not just 6. Service delivery, health financing, and governance, just to make the point that health financing is only one of the building blocks, and how it interacts with service delivery and governance matters in order to make progress towards universal health coverage, which means whether or not you're having effective service coverage, as well as financial risk protection and risk factor mitigation. And one key point about universal health coverage is that it really sheds light on the fact that the way in which you finance health systems matters. So it was one of the few sort of indicators that said, when you get sick, your wallet also gets sick, and so you need to sort of look at those two. And the way we track progress towards universal health coverage, this is recommended tracer indicators together with WHO. We are co-custodians, the World Bank and WHO, of SDG 3.8.1 and 2. That sounds incredibly glamorous. It's just 3 people in WHO and 3 people at the World Bank, including me, that every 2 years take track of where countries are. And we have 14 sort of tracer service coverage indicators on RM and CH, on infectious diseases, NCDs, and so on and so forth. And then we also track what proportion of your population is spending large amounts of out-of-pocket spending, greater than 10% of the household budget and greater than 25%. There's also a sort of a auxiliary indicator, what proportion of households are impoverished or pushed deeper into poverty due to out-of-pocket spending on health. Again, making the fact that how you finance the health system is just as important as how much you're spending. And this is just to give you a quick overview. I hope you're able to read this, but this is from the latest global monitoring report that was released just a few months ago. And the left-hand side is showing you service coverage from 2000 to 2010 to 2019 to 2021. And just to make the point, yes, the region has made tremendous progress on service coverage. It's an index derived from the 14 indicators that I was showing you earlier. But actually, there are only 2 countries in the region that have reached the 80% threshold mark that's considered to be good coverage, and that's China and Thailand. So we still have a long way to go across the region, some countries more than others. And also the point about progress was interrupted due to COVID-19, which should not come as a surprise, but was evident globally across a whole range of countries. The right-hand graphic is summarizing not just service coverage on the x-axis, but also the financial hardship indicator, that how many people are spending more than 10%. So, and the point here is that in South Asia, East Asia in particular, service coverage has improved over time, but financial hardship has been worsening. So more and more people are spending more than 10% of their budget on out-of-pocket spending, despite the overall out-of-pocket spending going down across the region. So a bit of a puzzle that we're working together with WHO on. I won't go into details, but just to give you a flavor of the types of things that we're seeing that could be causing this worsening financial hardship. I'll just maybe point out one point, that there's improvements in coverage, but fewer improvements in effective coverage. That means quality of care still remains a problem across many countries of the region. And by quality of care, I'm using the Lancet Commission on High Quality Health Systems definition, in that both clinical and non-clinical dimensions of quality being important. So there's a lot of waiting time, there's a lot of perceptions of poor quality of care, stockouts of medicines, lack of availability of diagnostics, and so on and so forth. That still, despite having publicly financed coverage, many people in our region still end up spending out-of-pocket for accessing care, which remains a challenge. So I'm just going to end here and just sort of give you some key takeaways, and also as a backdrop to the others' presentations, that there's this huge diversity across Asia-Pacific in terms of how health is financed and in terms of attainment and universal health coverage. Many countries still need to catch up. If we stick to current trends, there's no way we're going to get to this UHC SDG target by 2030. High out-of-pocket spending and financial risk remains a challenge, especially for South Asia and developing East Asia. Financial hardship continues to worsen despite overall declines in out-of-pocket spending. Pacific countries are sort of different in that they have had low out-of-pocket spending, but despite the fact that they spend much more from the public purse, their output indicators are much worse than expected. So that suggests, just having more money is not the only thing. How you use the money, how you allocate resources matters just as much. And important to examine ways in which health financing intersects with governance and service delivery, PFM challenges to understand barriers to WHC progress, and sort of in this post-pandemic era, it's important to relook at how we can accelerate and make progress towards universal health coverage in the Asia-Pacific region. So I'll stop here and hand it back to Luis.
Thank you very much, Ajay. Fantastic presentation. Okay, Ajay has brought us probably the big picture. He brought us actually in an helicopter. We know the composition of expenditures that we can find in across Asia and the Pacific. He also brought us the point that we have progressed a lot on coverages. So many people use the services that they need, but we are not going the right way on financial hardship. Many people actually, it's 2 out of 5 are suffering catastrophic health expenditure, are spending an unreasonable amount of money. And this is what Ajay was referring as part of our joint effort to monitor progress towards WHC. Now we will leave the helicopter out. We are going to go down to a country, and we're going to start, and it's a great privilege, we're going to start with Fiji. And it's a great privilege that we can count with the Minister of Health of Fiji. So let me introduce the next speaker. It's Honorable Dr. Ratu Antonio Rabitsi Lalavalavu. Let me read a bit there. Dr. Ratu Antonio started his political career after he contested the general elections in 2018. And in the same year, he was elected as a representative to the Parliament of the Republic of Fiji, as a member of the opposition, spokesman and shadow minister of Health and Medical Services, and as a substantive member of the Standing Committee of Social Affairs. Since 2023, he has been appointed as Ministry of Health and Medical Services, and since he has arrived to the office, fantastic primary health care reform is starting to work in the country, and we want to know more from it. Thank you very much, and welcome, Dr. Antonio.
Bulavinaka, and very good morning, I believe, to you all. Just for the information, I have no background in the financing or economy. But nevertheless, in terms, just grateful to be here to share Fiji's experience in terms of health financing priority in Fiji. And our disease burden and commitment to address the national, regional, and global health targets such as SDG targets and other health priorities of government inform and determine the policies that guide health services in Fiji. So to address this, the ministry is working on transforming our primary health care programs, as alluded to by Luis, as the vehicle to achieve universal health coverage for the people in Fiji. Through this primary health care approach, we hope to reach all our communities, particularly those in the remote areas, hard to reach places due to geographical isolation, vulnerable populations, include the mothers, babies, elderly, disabled, and so forth. Just before I go forth, I thought to mention about Fiji. In the context, Fiji is made up of 300 plus islands. We have over more than 200 healthcare facilities. It's publicly owned by government, and therefore, in terms of services being provided, it's fully funded by the government. Nevertheless, we have private hospitals and other private facilities that do provide much needed services. With that being said, so Fiji is currently working at the moment with WHO, World Bank, and other partners in developing primary healthcare packages for health services and health facilities. So these primary healthcare packages will be made for purpose with all our facilities. Our facilities are still in the referral system facilities, whereby we have the division hospital as the main hospital, and also the tertiary hospital. Then as you move down, then you have the subdivisional level health center and a nursing station. So different packages from primary healthcare for different settings, and that is what the part of our reform is. And together with primary healthcare, we also are prioritizing access to medicines. For example, to address the NCD medicine crisis, government has included prescribed medicines in the list of VAT-free products available to the people, significantly reducing the costs of medicines when purchased from the private pharmacy or retail pharmacy. And again, prescribed medicines as NCD medicines and antibiotics solely in our pharmacies are more accessible now than ever before. For the ministry, we have also, in terms of medicines, we've also fully developed a medicine inventory management system called M-Supply. That was through funding from one of our donors. And to all, it's been made 100% effective through all our health facilities. So the system has allowed a better organization and coordination of our medical supplies, including redeployment even between the facilities. And another issue in terms of prioritizing health is on our health infrastructure. The ministry is prioritizing this area on improving health infrastructure, both within the sphere of what government can do, budgeted for, and also we are reaching out to our development partners and other lending partners to come on board and assist us with this. And at the same time, in terms of improving universal health coverage, we have done a little bit of reform in terms of our spending. Initially, it was centralized into the main headquarters, but since taking office, we've allowed it, the minor works, to be decentralized to our division so that each divisions can take ownership of their program and spending likewise. But the monitoring has to still be there, and we continue with that. Together with that, I had mentioned about partnership. Fiji at the moment is strengthening its community partnership with not only within the community, within our private sector. We also, within our private sector, as part of the social corporate responsibility, we're also reaching out to our development partners. Our neighbors, Australia and New Zealand, have been assisting us in taking on board the priorities, as mentioned, in terms of our priorities on primary healthcare approach. That being said, we're also looking to funding lending agencies such as World Bank, ADB, and to assist us with this. Our percentage of GDP spending in health is a bit low, and that is why, even though we got much of the budgetary allocation for this financial year, but as always, it's still not enough. Therefore, we look forward to our partners, not only abroad, but locally, and some have stepped up and taken on board their corporate social responsibility to assist the government in financing some of the programs and infrastructure improvements. That is in a nutshell of what Fiji is currently doing in its primary healthcare reform in prioritizing health financing in our primary healthcare reform. Thank you.
Thank you very much, Honorable Minister. Just to put the dots together, Fiji has a system based on budgetary arrangements and a public delivery of services, mostly together with this increasing role of the private sector. But the reforms that the Honorable Minister has lined up, improving the infrastructure, so having a better supply side available, medicines, and this point of medicines is critical because one of the main drivers of financial hardship in Asia and the Pacific is medicines outpatient. And this, many people think that the problems are when we have an acute, very expensive condition that brings us to hospitals. But the reality in the evidence that we have generated is that outpatient medicines, particularly for chronic patients, particularly for patients in households with elder members. This is where the problem, and Fiji is from the supply side, increasing, making them more available in the public facilities. It's a very good policy to go. Another important point made by the Honourable Minister is the redefinition of services, and it's a good entry point when countries are starting to rethink about primary health care. It is, okay, what exactly are we effectively delivering, quoting a bit Ajay's point on quality. And the last point, the centralization, all the governance arrangement. It's about primary health care, it's about an accountability reform. And even when Australia is trying to move away from fee-for-service towards blended payments, at the end, it is a way to say, let's pay our providers in a way that it's linked to our policy goals, links to quality, links to coverages, but of course this assumes that they have some margin of maneuver and some autonomy. So all these details matters a lot for when thinking in reforms and looking at what is the role of health financing on it. Okay, now the Minister of Health has talked about the support of New Zealand in particular. So now let's have a look at the role of aid, the role of international partners in supporting through health financing reforms, through resources, but also through assistance these reforms. And for that, we have the great privilege to have Dr. Rohan Sweeney. He's a Senior Research Fellow at Monash University Center for Health Economics and has put a lot of research into aid effectiveness. Rohan, thank you. Welcome.
Okay. Thank you, Lewis, and good morning, everyone. It's a real privilege to be able to speak this morning. So as RJ has already given us some insights into, many countries in our region do rely on health aid to support their health sectors. And, particularly in the Pacific, where some countries rely, or 30, 40, 50% of total health expenditure annually actually comes from health aid or external assistance. Historically, the evidence on the effectiveness of health aid has been mixed, but increasingly the evidence base is showing that health aid has had success in achieving improved health outcomes. But what we also know is how health aid is delivered matters. The relationship between donors and recipients is inherently uneven. Donors can ultimately decide how their aid is delivered and what it's used for. Currently, many donors are really now starting to heed the call for locally led development, and we heard a lot about that this morning in the plenary session. Listening to local priorities and supporting local solutions. But I want to just go back in time 20 or so years to the Paris Declaration on Aid Effectiveness, which was also established a movement that sought to give greater voice to aid recipients. Through principles of effective aid of effective aid delivery, harmonising donor activities, aligning aid with recipient priorities, and ultimately giving recipient country governments greater ownership of their aid programs. In health, perhaps the most prominent operationalisation of those principles was the sector-wide approach, or SWAP. The SWAP truly did encapsulate those aims in how aid programs should be managed in partnership between donors, development partners and recipient countries. But they've lost momentum not that long after the launch of them. And I think a big part of that was the lack of rigorous evidence on their effectiveness. Reliance on case study stories where experiences showed that perhaps donors only half-heartedly engaged in swaps. And there's evidence, research coming out of the Centre for Health Economics at Monash has shown that there was a real donor hesitancy, and that even for those poorest implementing swap countries, they actually saw levels of health aid, they saw less health aid than they would have had they have not implemented a swap. But our research has also shown some real positive outcomes from health swaps. That health swaps did increase recipient ownership of their aid programs, including dramatic increases from a very low level of health aid that was given in an untied way, or sector support. We saw countries that implemented swaps successfully reduce the level of health aid crowding out domestic government expenditure on health. So those dollars of health aid stayed in health, and so did government's own contributions and government health expenditures. And on average, swap implementing countries saw a 5 to 8% reduction in infant mortality. But these outcomes took time to come to fruition. And so, with my last minute, I'm guessing, I just wanted to reflect on some of the key messages from that swap and that swap experiences and the Paris Declaration on Aid Effectiveness as we move towards trying to lead towards localisation and locally led development. So the key messages from our research and for moving forward are that increasing recipient ownership of health aid can and has worked. Development partners and donors that are a bit weary or have become weary or wary of coordination should take heart that their efforts in the past with swaps have yielded improved health outcomes. And I think these lessons from the waning interest in health swaps for scaling up locally led development. Maintaining momentum is going to require patience and donor confidence, and both of those require evidence. Donors are going to inevitably be working with local intermediaries for communities. Might be local government, might be civil society organisations. And donors are going to want to know that those intermediaries do truly understand local community priorities, and that requires research. Swaps struggled sometimes in managing this slightly complex dynamic alongside other global health agendas. And I think for locally development, there's going to be a lot of attention required to really harmonise locally led development approaches with some of these other global health agendas and funding systems, funding programs. Compelling evidence of effectiveness is going to be required. Swaps, the evidence came too late, I think. And so we really need to think about, as we move forward, to try and support locally led developments in the research world, that we look at designing really rigorous evaluation frameworks and methods, RCTs or quasi-experiments, and really in terms of data, how do we identify health aid that's allocated and that's flagged for specifically for locally led development, so we can really monitor the effectiveness of it. And I will leave it there. Thank you for your time.
Thank you very much, Rohan. First of all, congratulations. I think it's great that Monash has been investing on generating this evidence. I think swaps, and you put it very, very nicely, no? They got out of fashion too quickly. And your point that the evidence was not made available. It's probably one of the big explanations. Two comments there is, it's also, and linked to yesterday's presentation in the plenary session, the first plenary session with Ilana, the word trust, no? Because for swaps to be successful, you need trust. And actually also to bring the political economy angle, no? This evidence is very robust, but many of the issues with swaps, failure, if I don't want to use failure, I hope that they will reborn somewhere. It's that understanding the stakeholders' interests, no? Because you really need to work together, both governments, but all the political economy of partners, no? The mandates, the different institutional arrangements that they have, it's a challenge. And so I think it's very much welcome, this effort that you particularly and the university is putting to generate this evidence. Thanks, Rohan. Now, let's continue looking at modalities of aid delivery and actually linked to primary healthcare reform. So we will hear from a colleague from the Asian Development Bank. She is Ines Mikkelsen Lopez, and she's a senior health specialist at the ADB and will share a very interesting story on PNG. Thanks, Ines. Welcome.
Thank you very much to the panel members for inviting me today. Honourable Minister, esteemed panel members and members of the audience, it's a real pleasure to be here today. Thank you. As mentioned, I am a health specialist with the Asian Development Bank, also known as the other bank in our region, and I focus primarily on the Pacific region. So as Ajay has already gone through, he's shown that in the Pacific, the majority of health financing is coming from the governments, from the public sector. There's very little social health insurance across the Pacific region. However, there is, as you can see, a wide variety in the priorities that the governments across the Pacific are financing to health sector. We have FSM, which allocates about 4% of the government budget towards health. And then all the way at the top corner over there, we have Palau up at 24%. So there's a big variety. Today, I'll focus on a country that I have lived in, I have worked in for nearly a decade, Papua New Guinea. PNG is the red dot. We can see that PNG allocates about 8% of their government expenditure to health, which is not bad. It's more than, as I think Ajay mentioned, lower middle income countries are allocating about 5.4%. So in terms of the allocation, we could say, well, PNG is not bad how it does. But like we've heard from today and yesterday, PNG doesn't get the outcomes, and that's what matters, is how much it's spending and the outcomes that it's getting from the health sector. PNG has, unfortunately, one of the lowest life expectancies in the Pacific region, has low immunization coverage. About half of births are unsupervised, and it hasn't made a lot of progress over the last decade when it comes to health indicators. So together with the government of Papua New Guinea, the Asian Development Bank designed in 2018 a program called the Health Services Sector Development Program. And this program really aimed to support the government to see how can we get better results from health financing. And what we did is we wanted to look at all the issues that affected the health sector, the impediments to getting health sector results that were lying outside of the health sector. And it was key for us in this program to get the Ministries of Treasury, Finance and Planning involved in health sector issues. because without these ministries, there was barriers that were impacting the health sector that they could not address. And so what we did is we designed a policy loan, policy lending, which is budget support. It goes straight to the government, straight to Treasury at this stage. But all of 4 ministries had to work together. They had to come together to achieve policy actions and achieve certain goals. And these were around making sure that there was enough financing to the health sector, safeguarding that financing, ensuring that it wasn't going elsewhere in the budget, ensuring that financing was released on time and in full amounts to the health sector, all the way down to the decentralized levels. So we wanted to try and improve or use this budget support to improve the line of sight of health financing in PNG. This little diagram, the other diagram you see here on the slide, comes from a report for anyone who's interested in health financing. We published a report in 2019 called The Line of Sight, Improving Health Financing in PNG. It's available online. And it goes through the number of issues that are in health financing in Papua New Guinea, looks at planning, looks at how to improve spending and to achieve that better performance, and also the reporting back from the performance back to the central levels, so that Treasury and Finance know what results they're getting when they allocate more financing to health. And that was very important to have that flow of that discussion. In the report, we have about 15 recommendations for the government that we're slowly working with the government to implement over time. The HSSDP, or the budget support program, then incorporated these policy loans and the budget support together with the project financing. And project financing is more traditional financing. It's what we do. And that was really to support more immediate short-term issues in the health sector in Papua New Guinea, where we focus primarily on health infrastructure, trainings, digital health, rolling out a public health digital health surveillance system. And the project financing was co-financed by the government of Papua New Guinea and the Australian government. So this is an example of what we do under the project investment. We have financed, or we will finance under HSSDP, 16 rural and remote district hospitals and health centers. This is one in the East Sepik region of Papua New Guinea. It was finalized, we finished it in 2023. It's called the Mbunti Health Center. As you can see, some of the features in terms of the health center, first of all, was in terms of the location. We, as part of the project, we requested that the provinces send applications for a civil works, and obviously we got many applications. So we had to focus, and we used a criteria that focused on need. So we looked at where the greatest need was. We looked at the engagement from the local member. And so the local member had to ensure that there was safe passage to the health facilities. They had to ensure that the road and transport was there. And then we also looked at the allocation of health workers. So to ensure that whatever new facility we were financing, there was going to be allocated staff to be able to be on board. And for that, we also, as you can see, the back of that health center, we've built staff houses. In this particular case, we built 16 staff houses. And this was to ensure that the staff had a safe place to live that was on the health facilities and within that campus. And we had security around that to ensure that they were safe. Other features of this was all the procurement was done locally. We used local contractors. Even local village members were used and engaged to provide food to the construction companies, to provide local security. So that local engagement in terms of the site selection and the whole construction period was very important to the success of these projects and then the ownership of the facilities. At ADB, we like to call ourselves the climate bank of the Asia Pacific. And so climate mitigation, climate adaptation is very important as part of our financing. This health facility, as with all our health facilities, has solar panels. It is entirely self-reliant when it comes to water and energy. And it's been built to withstand earthquakes and cyclones. So this particular one actually has withstood 2 earthquakes without any severe damage. And we're always looking at ways to improve the climate adaptation of our work and our infrastructure. And since then, this health facility has been operating, and we're very pleased to start seeing some of the results that are coming through with this. We'd also like to just point out too that, as you can see, this is the operating theatre. We've chosen blue as the colouring, and this was important following consultations with the community because we didn't want it to look too clinical. We want it to be a space where people felt they could go in without fear. Some of the key takeaways from my very brief presentation. was that PNG has some of the poorest health outcomes in the Pacific, despite not being one of the poorest countries. We know this is a variation of factors, including the decentralization of health services, fragmented health financing. It's a very complex geography for anyone who's traveled around PNG. But there's also demand-side issues, and that particularly comes through when it comes to vaccinations and financing outreach services. The other major takeaway we'd like to say is that there's so many factors that sit within the health sector, but also outside of the health sector, that require a whole-of-government approach. And it was incredibly important for us, and we continue whenever we go back to PNG on review missions to ensure that we're meeting with those central ministries so that they understand the progress. As some of you know, ADB we finance via loans. The government has taken on a loan for this project, and therefore it is a whole-of-government responsibility for us to ensure that there's results as part of this project. And then lastly, I'd like to mention the fact that it is possible to build climate-resilient health infrastructure. It takes us about 1.5 years, and we've seen incredible results in terms of the maintenance of these health facilities through various climatic events. Thank you very much.
Thank you very much, Ines. Fantastic developments in PNG. Just a couple of reflections additional. The important that ADB has put attention on what I call the pipes, where the money, the public money has to flow to make this difference, and understanding how the public finance management works and improve it. It's a priority, and because if it's not addressed, it really, this desired impact is not going to happen. And it's great that it's a focus on the ADB projects. And then the reflection also on the, for primary healthcare reforms again, it's one very fundamental basic thing is supply side readiness. And it goes beyond the building. It's great, and actually PNG and other countries in the Pacific requires this upgrade. But also I like particularly the sensitivity to staff has to be there, and the working conditions, including having the houses, and considering this, to think beyond the building, right? Even if it's a climate resilient building, and that's particularly important with the shortage of workforce that we have not only in the Pacific but across the region. So linking the two things, it's really a very welcome move. Thank you very much again, Ines. We have 2 more presentations, and I think we try to keep them short, to pass 3-4 messages, because, for you to have enough process time, process space in your brain, because otherwise it's a lot, and then to have some time for questions. I hope that you have plenty of them. So the 5th presentation is about, now we're going to travel to bigger country, neighbor, Indonesia, and also which is undertaking very exciting primary healthcare reforms. So we have Dr. Tiara Martias. She's a lecturer in global health in the University of Melbourne and an expert in Indonesia. Thank you very much. Welcome.
Hi. First of all, I'm Indonesian, so I can talk about my country. Right. I work at the Nossel Institute for Global Health, mainly on maternal and child health and health financing. And there is an exciting transformation going on for the primary health care in Indonesia as part of the larger health system transformation. So a bit of a background, we still have a lot of maternal health, neonatal and child health burden, but also we're looking at, increasing, like any other country in the regions as well, infectious disease outbreak, but also non-communicable disease. So non-communicable diseases in Indonesia, including cardiovascular, respiratory problems, not because of infectious disease, are currently the leading cause of burden in Indonesia, and I'm sure in pretty much in other LMICs as well. So the question for the government is, one, is the health resilience, because of COVID mainly, but also how to tackle behavior change, more focusing on promotion and preventive medicine. So the transformation largely focusing on the primary healthcare level. So it tries to integrate services throughout the life cycle. So from the conception of babies, for example, until adolescent and throughout life, but also for non-communicable disease, meaning that early prevention of non-communicable disease and expanding service delivery points to villages, again, focusing on preventive medicine, but also health system resilience to health shocks. So they're also putting in place local area monitoring, that's what they call it, really to monitor the health status of the population, including infectious disease or non-communicable disease, and using dashboard for real-time population health data. And a lot of money and investment are going into this as well in terms of infrastructure, but also human resources for analytics and policy making. The thing about Indonesia, it's decentralized, and it's a very complicated decentralization because it takes place not at the provincial level, but at the district level. And we do have around 500 districts operating its own system with various capabilities in terms of healthcare access, but human resources as well, and financing from the district level. So, for example, our primary health centers, there are around 7,000 sub-districts, and village health level centers, which is 83,000 villages, doing different programs in health through various healthcare service delivery points, including through integrated community health posts, home visit, down to the community level. And to bear in mind as well, Indonesia is around 65% are private sectors. So even if we want to transform the primary healthcare in Indonesia, we also have to talk about largely a private sector that makes up the whole health system. With the transformation, it's quite promising actually, because we've been trying to tackle a lot of the problems at primary healthcare, and the recent health system transformation largely focuses on the primary healthcare. And a lot of money is being drawn into it as well. But also, again, with the decentralization, we have multiple funding mechanisms for different level of programs and different levels of needs as well, and different level of government. So, for example, the national government transfer money either directly to the provincial level or to the district level or to the primary health center for different levels of different types of programs. And one of the health financing system transformation that is part of the health system transformation is what they call a health financing consolidation, which is trying to put everything together in a more meaningful way. One of the ways to do that is through what we call a minimum service standard, in which each district in Indonesia must meet a minimum level of health outcomes. For example, for NCD, at least, for example, 80% of people with hypertension are diagnosed and receive effective coverage, like Ajay said. And then try to make out or work throughout the different funding mechanisms that are in the country, including from donors as well, which is not too much in countries like Indonesia, to be able to work it out at the primary healthcare level, at the clinical level, and at the community level as well. So I wanted to leave this presentation with a bit of a hopeful point. So again, the health system transformation in Indonesia that was started last year and now it will be carried out by the new government, which is going to be in place in October, has a lot of potential to focus more on primary healthcare, in which I think our region and across the globe, primary healthcare strengthening has been one of the greatest agendas. But we do need more evidence and monitor it closely in Indonesia and other places as well, so that money don't go to waste. And whatever health outcomes we want should be equitable throughout the community. Thank you.
Thank you very much, Tiara. Fantastic presentation. Important to make sense of all these flows of money that are going. And I think that the case of Indonesia is very interesting. With these three pipes of money. One at the district, one comes from the province, and then you have one coming from the insurance, and the other comes from the government. It's very challenging. And one important point that you said, but a bit quickly, is what I call focus on the denominators. Many reforms happens, and the underlying assumption is I need to take care of everybody coming to my health facility. And I evaluate the performance based on I have treated correctly the people that has come to the facility. But primary health care is not about that. And you have said it. It is how many people on hypertensive are out there, and I'm responsible to take care. And my performance, someone going to evaluate my performance is going to base on that. So the people that not have shown in my facility, And I think that focus, which we know, but it's not happening that often when countries are launching primary health care reforms. And I think it's very inspiring. And actually Indonesia, and maybe Ajay can add later, is inspiring the region because of the ambition of the changes that you are pursuing. So thank you again very much. Last presentation, and I think we will have good 25 minutes of Q&A, is last but not least, is with wait. Kati Michalopoulos is the head of the Monash University on Health Economics Group, and she's going to bring us a very important part on health financing and health economics, which is economic evaluation. The floor is yours. Thank you.
Thank you. Now, Lewis thinks that we might have time, but anyone that knows me knows that I like to talk, so maybe not. Anyway, no, I jest, Lewis, there will be time. All right, so I'll be talking about, I guess, the question of, hypothetically, we've got some money, we've got finance, how do we spend it? What do we spend it on? Which is a really, really important question. Now, let's just make sure I do this in the right way. No, that's it. Now, I am a health economist and I'm an economic evaluator. And so we spend a lot of our time and a lot of our research basically working out the cost effectiveness of different interventions. But in reality, that bit of what we do is part of usually a larger process of what we might term loosely health technology assessment. And so I thought I'd just quickly start out this talk off with familiarising you all in our mini masters coverage in terms of what is health technology assessment. So many countries around the world have formal health technology assessment agencies. Certainly here in Australia, we were forerunners in this space. A lot of the developed countries have them, developing countries are, I guess, building. But it's not a single thing that informs health technology assessment. It's not just economic evaluation. Things like medical ethics, evidence-based medicine, health services research, medical sociology, health economics, outcomes research, medical decision-making are all really important parts of a robust and informative health technology assessment process. And as I said, it's systematic and a multidisciplinary evaluation of the properties of health technologies. And when you think of the health technology, I think a lot of people think it's a machine or it's a blood test or it's something like that, but it's not necessarily. It could be an intervention. I work in mental health, so often it's psychological interventions. It could be a service. It could be a model of care that you can absolutely apply these principles to. And it's used to inform the question of what to finance. So assuming we've got finance, how do we spend that money in the best possible way in order to improve our society's health outcomes in an equitable and way that matters to our society? And I think that's important because different societies will have different priorities. And health technology assessment is important also at a local context, but we'll come back to that. So it's focused on value and guidance on how technologies can be used. Efficacy tends to be a major focus on health technology assessment. Does this new intervention, does this new pharmaceutical, does this new model of care work? And I guess, we're all familiar with randomised controlled trials and outcomes research, and that's a question that gets answered. Economic merits is this new pharmaceutical intervention model of care, cost effective, tends to focus in health technology assessment, but it's done variably, quite variably, and different countries have different approaches to how they do it. So I've just gone backwards. All right. So where is it used? It's used here in Australia, it's used a lot in terms of our pharmaceutical benefit scheme. So what do we put on our PBS in terms of drugs? Medicare Benefits Advisory Schedule, which is our medical interventions, blood tests, imaging, lots of other things. In other areas of health, especially state-based services, it's not formally used. So that bodes possibly for inefficiencies. In areas like the UK, there's NICE, which you're all probably familiar with, and certainly within our Asia-Pacific region, health technology is certainly growing in focus. For example, Singapore's made great bounds in terms of their agency for cost effectiveness. In Thailand, there's HITAP. But not all countries have the capability to have these separate kind of health technology assessment agencies. And they're our very good friends in the WHO, have helped us for a very long time through the publication and real spearhead of methods through their WHO generalised cost effectiveness methods or their WHO choice methods. So it's used broadly, growing in certainly lower and middle income countries. Now, I'm going to give you a couple of examples of this kind of work and where it can be really impactful that we've done and led by Yonghe Lee, who's in the audience there. So any technical questions, I'm just going to handball to Yonghe over there. But this is some work that we've done in collaboration with the WHO, which is looking at the cost effectiveness of regulatory pesticide bans. Now, mental health and suicide prevention is an area that our team does a lot of work in. Now, pesticides are a leading cause of suicides in the Asia-Pacific region. That might be news to some of you. And in some areas in the Western Pacific region, pesticides are the cause of just under 50% of deaths by suicide. Now, when I looked at that, I thought, no, that cannot be true. And I went to the meta-analysis, and that is true. In many other countries, it's a lot lower, but in that particular area, it's really, really high. So that's a massive problem. There is strong evidence from countries like India, Sri Lanka and South Korea, showing that regulatory bans of highly hazardous pesticides can greatly reduce the suicide burden without actually reducing agricultural yields. Because as economists, we're always interested in, what are the broader impacts of some of these things. So you're saying, okay, so if you can't use the suicide, you can't use the pesticides, what will then happen to our agricultural yields? And there is some evidence showing that we can do things differently without having a huge impact. So in 2021, we published a WHO-sponsored study that demonstrated the cost effectiveness of banning highly hazardous pesticides could lead to reductions in suicide. And that's the joy there for those of you that might be interested. And this study, the findings of this study have actually strengthened the evidence base for this policy intervention and has had some good policy impact around the world, which we're very pleased about. Because one thing now as academics that we're asked to think about is how can our research actually inform what actually happens on the ground? Because really that's why we're doing it. We're not doing it for other academics to read and to cite, but actually to make a difference. That's why I came into health economics in the first place, to actually make a difference. And this is just a table from the results of that work. And unsurprisingly, it shows that it is quite cost effective to ban these highly hazardous pesticides. And of course, it is most cost effective in the countries that have higher suicides that are attributable to these deaths. That kind of makes sense. And these numbers are, pretty cost effective, even when you compare them to other kinds of interventions in non-mental health kind of areas. Another example that I want to talk about today, and this is my last example, are school-based social and emotional learning programs. Now, these are really important, and they're important right now. And why are they important right now? Because we have a terrible situation where the mental health of our young people, not only here in Australia, but really around the world, is worsening. And it's worsening in rates that I would say is unacceptable, and we really have to do something about this. And this is in all areas of the world. So We have evidence mostly from high-income countries that indicates or shows that socio-emotional learning programs, and these are programs that focus on things like teaching children to be resilient or problem-solving skills, cognitive restructuring, maybe how to think about things in more helpful ways, are effective in improving their mental health. In 2023, again, along with our collaborators and good friends at WHO who sponsored this work, we evaluated the cost effectiveness of delivering these school-based social and emotional learning programs in lower and middle income countries. And guess what? They were pretty cost effective. And again, equivalent cost effectiveness ratios to other kinds of health interventions, non-mental health interventions within those regions. A separate return on investment study that took, I guess, a longer-term perspective that took our results and sort of projected longer term into the future. And I must say, we're fairly conservative in our modelling assumptions. We don't move too much beyond the evidence in terms of hypothetically what might happen 20 or 30 or 40 years down the track. We don't know often, so we tend to stick to the evidence. But this return on investment study kind of projected forward and found potentially massive cost savings if these interventions were rolled out. And there is emerging implementation of these sorts of programs amongst lower and middle income countries, which is really, heartening to see, I guess. So it is, I guess, some evidence that doing economic evaluation that can help inform the question of what to finance can have an impact. However, so in summary, it is possible to undertake reasonable to high quality health technology assessment, including robust economic evaluations of interventions and services for many country contexts, including lower and middle income countries. Now, the problem there is that local data can be highly variable. So Yong-Yi, while doing this work, has travelled to countries where he's had a look at locally what kind of data sources are available in order to help inform our modelling, to try and be as accurate and robust as we can be. And some countries are better than others. Some countries might gather some data better than others, and we can all do better in that space. So data is always an issue. The WHO provides friendly great tools and a lot of evidence where local capacity might be limited. And existing studies, we do have evidence that existing studies have informed policy and practice, but we still have a long way to go. And one of our biggest problems that other people have also talked about is ongoing monitoring and evaluation is a major problem. So once we've decided, yes, we'll invest in this new intervention or we'll ban pesticides, we actually need to go back and have a look at whether the interventions have been implemented in the way that they were intended to be implemented, and are they achieving the kinds of outcomes that we think that they're achieving, and if they're not, what can we do about it? And that is something that no one does really, really well. So I will leave you with that, and thank you.
Thank you, Kathy, and thank you all panelists to be patient and keep your presentations within the time. So we have 15 minutes, and I would like to invite all panelists to come to the stage, please. All. And we would like to give opportunity, because by now you are very excited to get into health financing. You are already looking at Monash or University of Melbourne, where their programs are starting. But while doing that, questions. Please, sir. Can you come to the mic here? Yes. You have raised a hand. You have a mic.
Thank you very much, all the panelists. Wonderful presentations and very important topic. Having worked in East Timor, Indonesia, Myanmar, Kenya for the last 32 years in public health, I think one issue which needs to be in the mix is the wasteful health spending, which we need to target. And thanks to Professor Kathy for mentioning health technology assessment. And I work with Tracy at Adelaide University, your field. So very important. Just give one or two examples to understand. In a country like Australia, if there are 2,000 surgeries which lead to unnecessary sepsis post-operatively, If we go to Myanmar's Yangon General Hospital, or one of the panelists is from Indonesia, you might know that Wahab Sarani Hospital, for example, in East Kalimantan, there might be 20, 30, 40% people in any surgical ward suffering from post-operative sepsis, wasteful spending, even some spending on one village, one midwife, huge program, sometime proposed by the WHO. Wasteful spending sometime, because if a midwife cannot deliver or does not deliver 10 babies a year or 12 babies a year, she will lose her skills very quickly. And administrative fraud, I won't mention fraud, but administrative costs I will call. So I think my question to the panelists is that what research is happening other than an individual working on these issues and trying to help one or the other institution in a developing country? What is happening at the global level? Are we looking at this issue? Why Sri Lanka has been able to achieve what many other developing countries, why Costa Rica has been better than the other country? Those allocative efficiencies issues need to be in the mix, because if in Australia we lose $2,000 out of 100,000, maybe we can sustain that. But if in a developing country there's only $100 available, and we lose 2 or 10 out of that to these wasteful, that's a huge sum of money, and we could do a lot more better. Thank you.
Thank you very much. This is working. So yes, very good point about wasteful spending. I mean, the examples you're giving are related to poor quality, right? So poor quality of care, because you don't get cost-effective outcomes, you end up having wasteful spending. And I can give you one or two other examples of the work that we're doing. So we are currently helping countries, including Indonesia and Vietnam, analyze their hospitalization data to try and understand what proportion of their hospitalizations are occurring due to ambulatory care sensitive conditions, so that weaknesses in primary health care, for things like diabetes, hypertension, COPD, asthma, if you don't have strong primary health care, you're ending up in the hospital, which at a system level is also wasteful, although at that point in time it's medically necessary, but over time wasteful spending. So this is also in terms of rational use of medicines, not overusing antibiotics. We're also helping countries analyze the ballooning rates of C-section that are happening. I don't know if it's there in the Philippines, but in India, and there's a lot of waste in terms of this being medically unnecessary. More than half the deliveries are happening due to C-section. WHO says it should be 10 to 15%. So it's in some ways, you said I don't want to use fraud, but this is a form of abuse or fraud, and very important, especially in resource-poor settings, to try and help identify some of these cases.
Please, gentle. Okay.
Thanks very much, panelists, for some really interesting presentations. I wonder if I could ask particularly Ajay and Inez to reflect maybe on intersectionality. You both talked separately about the importance of bringing other ministries, for example, to the table. I think that there are extensive co-benefits to be made by bringing in SDG-focused groups around, SDG 3 obviously for health, but also 5 around women, 10 around reducing inequity, and the ways in which the bank and the other bank can both facilitate that in their own practice, as well as implement programs that really bring other ministries and groups to the table.
Maybe I can get started. So yes, I think that's very important, especially for primary prevention, right? I mean, what good is having a very good health system if, for instance, obesity rates are rising in the country, or in South Asia, it's the issue of air pollution, right? So very important to look upstream and to try and work together with other ministries to try and understand. And this is also true for other forms of environmental degradation, also climate change. It's easier said than done. I think part of the challenge is we are all, sort of very siloed in the government as well as within the bank. Even for things like nutrition, you need to involve the agriculture sector. You need to involve other departments to work. It's an ongoing challenge, but clearly, in fact, if you saw some of the UHC indicators. We're trying to include things like water and sanitation, and in some countries they've also included air pollution exposure as worsening health indicators. So very, very important, very key. I think there's a lot more work that needs to be done in terms of raising awareness and moving away from this curative role of health systems to really also getting into primary prevention that includes interventions in other sectors. And I would say the same needs to be true also in other sectors. So, we in the health sector are usually very good at saying that please invest in other sectors because it's important for health, invest in education, invest in water. We don't do enough saying please invest in health because that's good for other sectors. Malnourished children don't learn. If you've got diabetes and hypertension, you're not going to be productive. So it goes both ways in terms of multisectorality.
Yeah, I'll just add very quickly. Yes, so like with the World Bank, our main counterpart is always Treasury and Finance in the governments. They are the ones who take on the responsibilities for the loans and grants. So that gives us an opportunity to say, well, if we're doing a health project, for example, in Samoa, we're doing financing HPV vaccines, we also then introduce the Ministry of Women to ensure that the Ministry of Women is also involved in this program, and it's not just seen as a health program or the ministries of local governments. So we have that opportunity in the way that we finance, but I think like Ajay mentioned, when it comes to programs like nutrition, or even I think yesterday there was the nursing education, when you're looking at various ministries, it's really ensuring that we have that ability to bring them together. As I mentioned, one of our strongest tools is that policy-based lending, where the whole of government has to come together to achieve those actions, and that's probably the most powerful tool we have to bring them together.
Thank you. My name's Vince Chadwick. I'm a journalist with DevX. I had a question for Ines about the PNG hospital example, because it's very interesting, an MDB doing this kind of health work. I know I've just been in Brussels, and the EIB and others are desperate to do this kind of work and are often criticised for not doing enough on human development. So it's interesting that you've done this, but I had a few more questions about how it was all structured. So I understand the Australian government provided a grant as part of that as well. Is that 38 million? I was Googling during your talk. So I'd be curious how you structured the deal, so the mix between the grant and the loan, when the loan needs to be repaid, the interest rate on the loan, how many people are using the hospital, and how much are they paying? That would be my question. Thanks.
I'll be very quick. Obviously, all our loan terms and lending terms are available online. You've obviously done your research. We're very grateful for the Australian government to co-finance this project with us, and so by doing so, they entrust ADB in terms of our ability to administer their resources. We don't make a difference by saying this health facility was financed by Australia or this one by government of PNG or ADB, because in the end, it's a whole team that's involved. It's a big team within the Department of Health in Papua New Guinea. It's a big project management team, and we don't want people to feel like they're being siloed depending on whether they're there on the grant or the loan. We are very grateful for the Australian government to come in with a grant, because ADB is not able to provide grant financing to Papua New Guinea as part of our country income status. So, but I'm happy to talk to you separately if on the loan terms, if I haven't answered that here. Thank you.
Hello, Harvey Liwanag, Nasal Institute for Global Health. My question has to do with spending during COVID-19, and I think during the pandemic, many countries spend a substantial amount of money. Some of them loans. For example, in the Philippines, in the aftermath of COVID, debt to GDP ratio has risen, and so I worry that because of that situation, do we still have enough money for UHC? And sometimes I worry that when ministries of health, for example, will speak with the finance ministry, they will say, oh, we spent so much money already for COVID, so maybe UHC might not be a priority. Is that a real challenge you see? And if so, how do you think we should address that?
Can I answer? Thank you. No, I want to answer with a reflection because yesterday Ambassador De Luca was making your point. No, we have spent too much. We don't have enough money. But then actually the slide of Ajay, where this mathematical form was there, it actually expressed the point, which is in Asia the size of governments are small. When you compare to OECD countries, the average size of a government is size of government measured by the income out of GDP. It's 35%. If you look at many countries in the region, it's below 20, including, the Philippines, I think it's 18, but then you have Laos, Sri Lanka, Bangladesh, Mongolia, below 15. So basically, the governments are not taxing, are not mobilizing domestic resources. So this debate of we have stretched our public finance during COVID, I think it needs to be put together with this other debate. Are we making an effort as a society to fund our social sectors? And I remember a paper for IMF of 20 years ago that was calling 15% as the minimum to start paying your basic social services. And some countries are not reaching that level. So we could discuss until the weekend about what is on whether there is this space or not. But I think that if we don't bring the second part of the discussion, is not a proper discussion on the topic. Someone wants to challenge my point? Okay, please. Whoever has the mic closer. Okay.
Russell Gruen from the Australian National University. One of the more interesting editorials in the New England Journal of Medicine that I've read recently is a couple of weeks ago when Eric Reinhardt proposed cash transfers to individuals as a way of promoting health and addressing the political economy of health. Are the banks considering that, and what do health economists across the world think about that approach?
I'm sad.
Maybe we can also ask others to come in, but yes, there's plenty of evidence to suggest that conditional cash transfers for prevention and promotion work, and in many ways it's negative out-of-pocket spending, right, or negative user fees. So rather than charging people to use, you actually pay people, especially for immunization and antenatal care. For instance, in India's got now 90% institutional delivery rates, in part because of a very small conditional cash transfer program that encourages women to deliver in facilities. So it is very much part of the sort of, given very large levels of informality, even sort of going for routine care, there's an opportunity cost. So in order to sort of offset that, from a systemic point of view, it's found to be quite cost effective.
Anybody else want to?
No, I would say we would need to really carefully evaluate anything like, and I think there is some evidence that it works in some areas and not maybe every area it might be the right policy lever to use, but certainly in some. But I think moving from tightly controlled studies or RCTs where there's shown good benefit into routine rollout where you've got different populations using things who are incentivised in different ways. And that's where we get sort of that knowledge practice problem in many things. So I think if we were to do something like that, it really needs to be properly evaluated out in the field in routine kind of delivery. And we should be doing that for everything. So I just wanted to...
Okay, thank you. We have 2 more minutes to go, so let's... Okay, one last question. Apologize for not being able to accommodate more. Please.
Okay, thank you. Thank you very much. I'm Swazik Elise Wangson, an economist at the World Bank Group. I have a question for all the panelists about the potential sources of fiscal space for health in general, in Asia and Pacific, and to what extent health financing can be made more climate sensitive overall for all countries in the region.
You cannot answer because World Bank. Fiscal space. fiscal space, way of generating, where can this fiscal space be generated? So additional resources, domestic resources.
So I will try and answer your question with in the context of Fiji. At the moment, it's as I had mentioned, it's mostly publicly funded by government, but there is space that we can explore in terms of national health insurance, maybe. But it is an idea that the government should need to explore it, and we will do. But at the moment, we, apart from the public financing that we do in terms of our healthcare delivery system, we have other private insurance companies that do come in and take up the space. So people who can afford it do take it up. But for ones that do not, then we can look into a national health insurance policy as a need to back up our current system.
I might just add something, just to pick up your point, I think, which was about climate impacts. Certainly in the area of economic evaluation, this is an area methodologically that's gaining a lot of traction lately, and probably has been for a while, but how can we better actually assess any climate impacts of health technologies or the way that we do things? So there's costs of delivering different interventions, but what's their carbon footprint, for example, is an area that is gaining a lot more interest, and we're now starting to include and measure within our economic evaluations to try and look at the broader impact of, I guess, you know, some of the conclusions of our studies to incorporate these sorts of very important and growingly important impacts.
Sorry, I was going to add one more thing. I guess particularly in the Pacific, when we're thinking of a lens of localisation, climate change and health at the community level are so intertwined, and so all health spending and all climate spending needs to really be thinking of that.
Just very briefly, this could be a 3-day workshop on fiscal space for health. But one area which is underutilized is health taxes, right? Taxes on unhealthy consumption, and even if the revenues from health taxes should not or need not be earmarked for the health sector, but the fact that they reduce risk factors. Health taxes on tobacco, alcohol, sugar-sweetened beverages, and also polluting fuels could be an area where ministries of health can be far more proactive, and they haven't been many times. Ministries of finance are setting these taxes with the eye of maximizing revenue. So you can do the math and figure out what's going wrong there. But Philippines, I think, is a good example of having used sin taxes to finance expansion in universal health coverage that we can examine more.
Thank you very much. This one. Okay. I follow you, ma'am.
Oh, thank you. I know you want to wrap up, so my question's been answered, but I was interested to hear from the Fiji Minister about how to make the case for health, noting that it's always a lobbying process for money within Cabinet. But I know we need to wrap it up, and I think we did get a bit of a touch on that in terms of health insurance.
Yes, as I've mentioned, that in Fiji at the moment it's mostly publicly funded, but there are talks underway on probably the introduction of a national insurance scheme that is still at the stage of probably the conceptual stage. But there is a need because with the current funding that we get from budgetary allocations, it's still not enough. As I mentioned, our budgetary as a percentage of GDP is slightly below the averages requested by WHO. So it is something that it's worth looking into, and as a government, we have to convince the Ministry of Finance and our PM that this is one way that we can look into to assist us in delivering quality healthcare for our people.
Thank you very much. So, of course, I want to ask for a big round of applause for our fantastic... Also for Tony for having give us the opportunity for inviting us to take part. We have learned a lot, and I hope that you have enjoyed. So enjoy your lunch, and thank you very much for coming.